Dear ESTS members and webinar attendees, my name is Lieven de Piepere, your moderator for today. This webinar is the 8th webinar and the last one of our 4th season of ESTS educational webinars. The subject for today is intraoperative electromagnetic navigation. I'm very glad to introduce you to our expert in the field. Marcelo Jiménez is Chief of Thoracic Surgery at the Salamanca University Hospital. He's Professor of Surgery at the School of Medicine of the Salamanca University, where he's also founder and director of the Clinical Simulation Laboratory. He has a special interest in minimally invasive techniques and new technologies, and therefore he will tell you everything about electromagnetic navigation. Difficult word to me. As you already know, we will ask your interactivity, so be ready to answer the poll questions and please ask as many questions as you want to the expert in the questions bar. If you just want to say hi to each other, please use the chat. I would say enjoy the lecture, and Professor Jiménez, the stage is yours.
Thank you, Lieven. Thank you for your kind introduction. Thank you, the committee, the educational committee, for inviting me today. It's a pleasure to share what I know about this field and with all of you. Of course, I can start with this question in order to know how the audience is. They know about these techniques or the facilities they have access.
So we published the first poll. You can see this in your right sidebar in the polls. And the first question is, do you have access to electronavigation bronchoscopy? So you can vote in the right sidebar. I see already some people voting, but there's many more. It's anonymous. We cannot see who is voting for what kind of answers. So please go ahead and then we'll see. And we can also comment on the answers a little bit. Okay, about half of you have voted already. So to the other ones, don't be shy. Professor Jiménez, can you see the votes?
Yes, I see. More than a half they don't have a platform for, 5% are planning to buy one, but they don't have also. Yeah, I assume that around 60% of the attendees, they don't have yet the platform for endobronchial navigation. Yeah.
Mm-hmm. So I think this will be very interesting for most of us today. And maybe we can already comment on that later, how difficult or how easy it is to get access. Maybe you can share your experience in there. Second question, maybe?
Perfect.
So the second question is the following. Do you have access to a hybrid OR? More than 2 days a week, 1 or 2 days a week, barely, or I would like to, but I don't have access to a hybrid OR. Again, you can make your vote. I'm sorry. Okay, a few more. So there we see that 60% is saying I would like to have one, but I don't have one. And it's only 9% saying I have more than 2 days a week access to an hybrid OR. So a little bit the same there. Most of the audience doesn't have access to the hybrid OR.
That's right. Great.
Maybe a third question then. How do you locate small nodules or ground glass lesions for minimal invasive surgery by electronavigational bronchoscopy? by a hook wire, by radio traces, or not? This is interesting because there's not really a winner there.
Yeah.
So 35% of the voters is saying none, so no location. We just go for a certain segment or wedge based on the CT scan probably. Then about 30% is saying electronavigation bronchoscopy, 20% hook wire, and 15% is saying radio traces. That's interesting. Would you already like to comment on this polls?
Yeah, I think this is really interesting for the discussion because there is a lot of people they don't have access to the endobronchial navigation platform and also to the hybrid OR facilities, and this is important in order to know how to try to incorporate this technology to their hospital or their practice. And also, is important the percentage of people that they don't use any kind of techniques for localization of ground glass because it's really difficult to find in many occasions. And I think this is an area to improve a lot in their practice. I hope to help people to give information and give tools for try to solve this this scarcity of instrument to work.
Okay, then I think we're ready to hear about that.
Okay. Let me share my screen.
Mm-hmm.
Okay. Okay, ready?
Perfect.
Okay. Well, these are my conflict of interest. Okay, one major challenge managing small indeterminate pulmonary nodules is we need a reliable method or technique to accurately localize and reach the target lesions for different reasons, to perform a diagnostic biopsy, but also to mark or label the target for surgical resection. I think this is relevant. And in selected cases, and I expect more in the future, to non-surgical treat this lesion. The hybrid operating room, I think this is a small but critical step in the management of these small peripheral nodules, because the ability to have a real-time high-definition imaging during the endoscopic or surgical procedures is a revolution and improve our current techniques of lung navigation and nodal localization. In this webinar, I will cover the use of electromagnetic navigation bronchoscopy technology, and also the percutaneous lung nodal localization in the hybrid operating room, as well to discuss the value and advantage of this integrated approach is what my good friend Bill Krinsky called hybridizing the hybrid OR. I will also review the future perspective on therapeutic role of the hybrid theaters in guiding surgery and local therapies. Electromagnetic navigation bronchoscopy was designed to extend the bronchoscopy to the peripheral airways beyond where it can be approached via traditional bronchoscopy. This is by using software-based reconstructed virtual airway and matching with the hardware-based real-time navigations. When compared with traditional bronchoscopy, endobronchial navigation bronchoscopy significantly increased the overall diagnosis yield in the biopsy of these peripheral pulmonary lesions. But for this, we need a 3D map, and the recommended CT scan and reconstruction parameters are the following. We need a supine and full inspiration breath hold CT scan, but with the arm at side. We all know that okay. We all know that the arm up reduce the dose and improve the quality of the CT scan image, but for navigation plan, we need to put the both arm at side, even if we lose our quality or we need to increase the dose. The dose is around 2-3 millisievert per study. We also need a multi-slide scanner with at least 16 detector or greater, and the protocol for chest, lung, or pulmonary embolisms, including the entire chest. And also, we need a high resolution, around 512 or 512, and we need to overlap the slides between 20 and 50%. And include a view of the entire lung and at least 1 centimeter of the trachea. These are the slide thickness, the slide interval, kernel, and filter from different manufacturers. And also, we can calculate the overlapping if we know the slide thickness of the study. Well, if we have a good quality CT scan, we can obtain this beautiful airway. You know? We can see with detail the peripheral bronchus. If we use a less quality CT scan, we start losing precision, we start losing details. And with poor quality CT scan, we can only see the main bronchus or the lobar bronchus. And this is completely useless to do a endobronchial navigation plan. Then we need a dedicated software to this planning. We need to select our target. If we plan to do a biopsy or to deliver an ablation treatment, we need to target the nodule. But if our plan is to perform a localization of the nodule, we can put the target, the green ball, between the nodule and the pleura. Then we have to look for the near bronchus in order to obtain the virtual bronchoscopy. This is the tools that I use with the superdimension system. This piece is to attach the working channel to the bronchoscope. It's different for each type of bronchoscope. Then we have the working channel with different curves in the tip. I prefer to use the 180 degrees tip. And we need also the electromagnetic proof for navigations. If our plan is to perform the endobronchial navigation without the accompanying CT, we can do the procedure under general anesthesia using an endobronchial single lumen tube or a laryngeal mask. I don't use sedation for this exploration, but it's possible for short exploration to use a sedation. Then we put the patient with the electromagnetic bore underneath, and we put the electrodes to create a 3D electromagnetic space in order to give information to the bore. Then we have to navigate in both bronchus to the upper and lower lobes to obtain this registration of the system to matching the virtual bronchoscopy with the real bronchoscopy of the patients. This is an automatic registration, but sometimes in this patient, for instance, this is a case with previous left lower lobectomy, and because the system cannot find the left lower bronchus, we have to review the registration in order to see if, as you can see here, the green line is matching over the virtual bronchoscope, and in this case, we can offset this registration without the left lower bronchus. Mm-hmm. Then, as we do in real life, when I drive a car, if we have a navigation system in our car, you don't use the navigation system to go to a street that you know well. We do the same when we start the navigation. We go directly with under direct vision to the segmental or subsegmental bronchus that we know we have to go. And when we reach this segmental bronchus, we start our peripheral navigation. I use, there are different type of tools. I use the 3D map static, and also this tool, the name is TIP. This consists in try to put the green ball in the middle of the screen. And when following this TIP tool is really easy to reach the majority of the green ball or the target we selected during our planification. Okay, what's happened next is the problem with divergence. Sometimes the tip of the working channel is not in the real place where the nodule is. This divergence, we can check or verify this by using different techniques. The more used is the fluoroscopy. We can use the fluoroscopy to check if we are in the right position, or even this the last platform from for endobronchial navigation from Medtronic. They can connect the platform with some type of fluoroscopy arc in order to obtain the real position of the nodule and reallocate the green ball where the nodule is now. This is because in lower lobes or when the movement of the patient are different during the procedure compared with when the CT scan was taken, this maybe happen. The other thing is, this is okay for solid nodule, but when we try to see a ground glass lesion by fluoroscopy, many times we cannot. In those cases, we can use radial EBUS to try to identify if the tip of our working channel is at the level of the lesion. Of course, the gold standard to do this is the Combin CT. But as you can see in this large trial, the Navigate trial, about the use of the electromagnetic navigation bronchoscopy, only less than 5% of the case they use the Combin CT. But using the Combin CT, you can make a segmentation of the lesion, and then you can create a volume of the lesion, and using matching this during your fluoroscopy, doing what is the augmented fluoroscopy. But the success to obtain diagnosis or to reach the lesion depend on the bronchus sign. According to the Suboy classification, Suboy type 1 is when the bronchus ends into the lesion, and the Suboy type 2 is when the tumor infiltrates the bronchus and the tumor is inside the bronchus. In both cases, the diagnostic yield is quite high. But in type 3 is when the bronchus goes around the nodule, and in those cases, the diagnostic yield plummets. Of course, in type 4 is no bronchus sign. The possibility to reach the nodule using only the navigation system is quite low. What kind of instrument? You can see here in this retrospective post-hoc analysis of the Navigate trial, the majority of the physicians, they use the biopsy forceps and the aspiration needle. Well, this is our workflow when we plan to do endobronchial navigation bronchoscopy combined with the combing CT. This is the setup for the room. We had to put a lot of platform and machines inside the room. We need to follow some rules. We try to put the platform for bronchoscopy and endobronchial navigation near the patient, the head of the patient, but we need also to put the ventilators, the controls for the combing CT, the tray for instrument, and the big screen to follow the procedure. But of course, we need to reserve the left part of the room for the combing CT arm. But if we plan to deliver a treatment during the procedure, of course, we need to add the ablation generator inside the room. You can see here the room, yes, during the induction anesthesia, you can see space around the table and here also. But from this, when we start the procedure, this is a zenithal camera, the view of this zenithal camera, you can see how crowded is the room. Is completely full of platform, machines, and so it is difficult to move around the table. Okay. Well, we are ready now to perform, to start our workflow for biopsy or to deliver treatment. But the first step is to do a CT scan. We do a spin and it takes 4 or 5 seconds. We had to leave to go outside the room to the controls. And then we can do segmentation using the software that the majority of the platform, for combing CT, they have. We can do the segmentation of the lesion using 3 planes. We can use the sagittal, coronal, or axial. And doing this segmentation, we can create a volume. Easy to see then during the fluoroscopy. We can also hide the chest wall structure in order to facilitate the matching of the nodule during the navigation. Then we can start our navigations. Here, this is, we do the fluoroscopy before, but now we start the navigations with the static 3D map and the tip, and try to put in the middle of the screen the green ball, and we follow this pathway. I don't care about the overlapping of this CT scan in the screen. I try to follow mainly this, put this green ball in the middle. Sometime before move to repeat a new CT scan before taking the biopsy, we can check with the fluoroscopy where is the tip of our navigation and system, in order to know if we have to do some correction just before go ahead with the CT scan. You can see here the tip is not in front of the lesion, and we can move, we can do some rotation and repositioning the tip against the tumor. In this other case, we start the navigations and we try to put the green ball in the middle of the screen, but this is almost impossible. This usually happens when we are in the wrong bronchus. And as you can see here, we are almost less than 2 centimeters near to the lesion, but we are in parallel. We are not in the right bronchus. In this case, we can do again fluoroscopy and try to withdraw the proof, the electromagnetic proof, in order to make some correction using the fluoroscopy before repeat our CT scan. And now we can resume the endobronchial navigation now in the right bronchus, and we can go ahead trying to put in the center the green ball, and finally leaving the tip of the endobronchial navigation system just close to the lesion. Well, then we had to fix the bronchoscope, and for this, there are different systems, different arm, manufacturer arm to hold the bronchoscope, but they are quite expensive. I took this arm from an old respirator. These are designed to hold the tubes from the respirator, and we can adapt this arm to hold the bronchoscope during the next CT scan. We exit the room and we repeat the CT scan, as you can see here, in order to check if we are in the lesion. We are now ready to go and to take a biopsy or to do needle aspiration. You can see here, in this case, we are in the center of the lesion with the working channel. We have to withdraw a little bit in order to take some distance to deploy the tools for aspiration or biopsy. You can see now when we withdraw a little bit the tip of the working channel, and now we take out the endobronchial proof, and then we deploy the needle for needle aspiration. As you can see here, the needle doesn't move the tip of the working channel. This is important, especially when we work in upper lobes. For that reason, we need to use flexible needle, because if we use the majority of the needle aspiration are too rigid and can move the tip of the working channel and change the direction. We can see now when we try to do a biopsy using heavy forces, this move the tip of the working channel and disalign the direction with the nozzle. We need for that to use pediatric forces are more flexible, especially in this biopsy in the upper lobes. Okay, we are now ready also to check if we are in position to apply the ablation. And you can see here the needle inside in the middle of the lesion. This is the correct position to deliver an ablation treatment. And also in this case, you can see how we deploy the needle in radioscopy, but also in this augmented radioscopy, you can see how the needle goes to the middle of the lesion, and we are now ready to apply the treatment. Sometimes we have to have a plan B. I always try to do this procedure by endobronchial approach. The risk of pneumothorax or hemothorax is lower. But you can see here, in case like this is a complicated novel localization, because it is in the upper lobe and in the posterior segmental bronchus. We try 3-4 times to reach the lesion, but we realize all the time what we are not in the nodule, and we are close, but we are not in the nodule. You can see here how in this CT scan the tip of the navigation system is not in the tumor, it goes around the tumor. After 3-4 intents, we decide to change our plan and change to percutaneous. The CombinCT, the majority of the platform, they have a software, dedicated software to plan how to do this percutaneous approach. You can select the target and also the entrance point in the chest wall, and then you can plan the direction, the distance, and so on. And then the system, put the patient in for fluoroscopy in the position to insert the needle. You can see here the needle is a dot. That means that the needle is in the right position to enter to the chest cavity. And then you can change the position of the arch to see the progression of the needle to the target. Using this, we are able to reach the lesion via percutaneous. Well, this CombinCT have also the possibility to guide the ablation treatment. We can plan how many needle or how many change in direction we need to cover the complete area of the tumor, but we can also have the volume of each application of the treatment, and also we can customize especially when we use thermal ablation, we can customize the treated area according to the temperature of the treated area. But we can also interact or change the plan during the application according to the segmentation that the system give us. We can also know the width of the ablation area and the length, and also the distance from the needle to the front of the ablation area. Well, we have to answer it is the NBA hybrid or new technology for us as a thoracic surgeon? I think the answer is yes, of course. For new technology, we have to follow the principles to incorporate this new technology into our clinical practice. We have to answer the question why to introduce the new technology and how to do that. Why to introduce new technology? The advances we know are often related to new technologies, but also the new technology often improve the patient outcome. And this new technology can make it easy and precise our work, driving our instrument to the lesion and giving us more precision during our surgical procedures. And what do we need to move to new technology? We need partnering with the hospital. We have to demonstrate that we are adding value, but we also need to be open-minded and proactive. We have to look for this new technology that can help to solve the problem we have in our daily practice. We also need partnering with an industry. The new technology usually comes from industry, but they have also resources for training and to provide the education to use these new technologies. But this is important to partnering with our peers, create groups, a group of interest, group of people working in the same field, because we have more training opportunities and we have staggered training. But the association with more experienced colleagues is important because we don't need to reproduce the same learning curve. We can learn from this expert and we can shorten our learning curve. But we also need to be patient. That means we have to do again and again and again. Nothing is more humbling than learning an entire new technical skill set, especially in front of other professionals who are watching us and sometimes they are expecting our failure. We have to be systematic for precision, and we need to record everything for debriefing and also for further evaluation. I took this training model from my good friends Sri Subramanian and Kelvin Lau. This is the training model for the majority of the new technology in our field is for bats and also for robotics. I think is valuable for training in the use of in the bronchial navigation bronchoscopy and the use of the compensity. But we need to add the training in bronchoscopy. But the training in bronchoscopy is in the portfolio of the thoracic surgery, must to be in the portfolio of the thoracic surgeon. And also we need a training for compensity use, but it is not so difficult as BATS or robotics, of course. And we need also to be certified in the use of radiological facilities in order to do in a safe way. Who is the specialist in charge of this new technology? I totally agree with this editorial from these three guys, these one pulmonologist and two well-known thoracic surgeons. We all are involved in the treatment of lung cancer. The ownership of diagnostic technology or test is something from the past. The specialists in charge of the new technology has to be trained. Are the specialists who dealing every day with lung cancer and working every day on that. And to conclude this presentation, I have to say that compared with conventional percutaneous approach, I think that in the bronchial navigation bronchoscopy reduce the risk of pneumothorax and is more precise for localization of the lung nodules. And I think this can really help to increase the adoption of minimally invasive surgery. I think that in the bronchial navigation bronchoscopy also increase the success of taking biopsies, marking, and make ablations. But the hybrid OR made the navigation even more accurate and allowed to monitor the endobronchial ablation process and also the ablation treated. With this technology, we will able to choose different localization technique for resection, for ablation simultaneously, without the delay which happened in traditional clinical pathways, where procedures are performed in several locations. This is the concept of one-stop shop. And finally, as the specialty of interventional pulmonology is expanding, I encourage to the thoracic surgeon to continue working in the field of the advanced bronchoscopy to make certain that this bronchoscopy and technology continue to be performed by thoracic surgeons. Thank you very much for your attention.
Thank you, Professor Jimenez. Very interesting. I also like the bridge you made to training and how you see the future of our training in thoracic surgery. Just having a look to the questions from the audience. You can ask questions in the questions bar. I see some questions already in the chat. So let's start there. First question. If you don't have a cone beam CT or intraoperative fluoroscopy, how do I confirm my tip is in the accurate position? Do you have any other tricks or possibilities?
Yeah, it's difficult, I told about the possibility to use the radial EVOS, but this is a expensive technology, especially it's cheaper to have a C-arm for fluoroscopy. There are another, platform in the market that try to drive this navigation without, but I don't have experience with those platform. It's really difficult.
Okay. Another question: do you do a specific CT for this? We do navigation bronchoscopy using the staging CT scan. The airway reconstruction is not as good, but is acceptable. Positive diagnostic rate is about 60%. Can you comment on that? Do you do a specific CT
Of
or-
course. The navigation system recommend some parameters to obtain the best quality of the bronchial tree for the navigation. I use sometimes, the CT scan performed before without the high quality. You are able sometimes to see in those CTs the peripheral bronchus, but the system don't recognize those peripheral bronchus just because the overlapping of the CT scan is not good enough. You can use this less quality CT scan if you are able to see the peripheral bronchus, and you can plan manually your virtual bronchoscopy from this less quality CT scan, of course. But now I think it's easy to perform with the CT scan we have now. With low dose, we can obtain high quality CT scan and just the same day of we do the exploration. Yeah.
And you always perform then your cone beam CT to make sure that you are in the lesion, or if you say, okay, I have a good let's say pathway through the CT I planned on beforehand, do you really need the cone beam CT to make sure that you are in, or not always?
Yeah, I have to say, if you plan to mark a lesion for surgery, you don't need it, the CT scan, because you don't need to know exactly that you are in the lesion, because we take some margin from the target. In those cases, especially in middle and upper lobes, I think is enough to do the navigation according to the previous CT scan. We don't need it. But for lower lobes, sometimes if you want to perform biopsy or needle aspiration, we need to confirm. If there is a good bronchus sign, of course, the fluoroscopy is enough. But if you have the facility to use the cone CT, is quick, is easy, and is 100%. The accuracy.
Okay. Do you perform surgery in the same room, and is it the same one as for your localization? I think yes, you have a hybrid room, huh?
Yes, of course. This is the main advantage. You can do both procedure at the same time. We usually, when we mark lesions, if we do by endobronchial approach, it takes no more than half an hour to put the patient in supine position with a laryngeal mask. We do the navigation and check if we want the where we are. And then we change the laryngeal mask and put on the endobronchial double lumen tube, put the patient on lateral position and go ahead. But even when we mark percutaneously the nodule, we put the patient in lateral position, prepare for surgery. We do put the hook or whatever we use for mark the lesion, and then we are ready to start the surgery at the same room. Yeah.
Okay, and there's the next question indeed. What do you use for marking? Do you use the hook, something else, the blue?
Yeah, I mix different depending of the nodule, depending of the deep of the nodule, or if it's solid or not. we use different techniques. Sometimes we use the hook, sometimes we inject the ICG along, or ICG mix with some contrast, radio contrast. Even sometimes in some case we use endobronchial navigation to mark one lesion, and hook or percutaneous approach to other lesion, depending on the characteristic of the lesion. Yeah, we have a couple, 3 cases with more than one nodule that I use a different approach for mark the nodules. Yeah.
Okay. I go to the questions bar now because the questions are coming in there. How does the pneumothorax rate look like in comparison to blind transbronchial biopsies with the mini probe? Do you have any numbers or comments on that?
Oh yeah. For localization nodule for surgery, I don't care. I don't see if we do if we perform a pneumothorax during the navigation or during the percutaneous approach. The next step is open for surgery. Yeah, but when we do biopsies, or I never see pneumothorax during our navigation for a biopsy of the peripheral nodules. We have, around 20% of pneumothorax, small, minimal pneumothorax. We are doing a CT scan just after the procedure. We can see really small pneumothorax after completing the percutaneous approach. But we only have to put like a tube in chest tube just one time, just because we have to treat the patient for ablation percutaneously. We need to pull back the lamp to apply the ablation during the procedure, and that's why we insert the tube, re-expand the lung, and then reinsert the needle for ablation. Yeah.
Okay. Another good question, which lesions would you go for the percutaneous technique, and which ones for the bronchial localization?
Yeah. Mainly, the more complicated cases for endobronchial navigation, and that means when you have to change 2 or 3 times the direction of the navigation, is complicated, because you start lose mobility to reach the lesion. Especially the upper lobe, the posterior lobe are really complicated for navigations, and also sometimes it's difficult to reach lesion really close to the diaphragm, because the movement, it is difficult to reach this lesion. We have to be prepared. I work, with a good friend, a good radiologist. We plan the majority of the case with a plan B, and this is important because we can change the plan in few minutes and do the procedure and obtain the final result we want 100%.
So your patient is also consented for 2 procedures then always?
Of course. Okay. Is depending on we ask the consent to the patient. We say we will start with this technique because we think that the complication rate is lower, but if we fail, we can then move to the percutaneous approach.
That's a good thing to do. A full OR with a lot of machines together can affect the magnetic field and the precision of the super dimension. Do you have any comment on that?
Yeah, of course. That's right. This is a good question. The navigation system, you have to check the navigation system before use it. And the engineer has to come with a different computer to check if you can use different machine and platform around in order to know if there is some interference between these machines and the navigation system. And of course, you have to check this before. The other thing is important when you take the CT scan, depending on the quality, but you have to disconnect the electromagnetic board to take the CT scan, because the electromagnetic field may interfere the CT scan, and that's I forgot a lot of time to disconnect the board, and then you realize that it's something with interference in the CT scan, and this is the electromagnetic board. Yeah.
Any preliminary data of the oncological benefits for the patients with lung cancer being pathologically revealed with electromagnetic navigation? Is the next question.
Oh yeah. From the point of view of diagnosis, I think we are adding more information. Yes, before I want to know in advance if I am operating a lung cancer patient or not. Waiting until the frozen section during the surgery to know if we are dealing or not with a lung cancer is a complicated thing, and you waste the time, sometimes waiting for the result. But I think we increased the diagnostic yield using the endobronchial navigation system and the compensity. But for ablation system and so, we need to, we now reserve the ablation for patient not candidate for surgery and patient not good candidate for SBRT. But probably in the future, we can start using when we have data supporting this treatment.
And do you have an idea of the diagnostic yield in percentage?
Using combining the compensity and endobronchial navigation bronchoscopy.
Mm-hmm.
Yeah, this is there are publication, and the increase of the diagnostic yield is around between 10-20% of, depending of the cases, of the selection of the cases. In our case, we have 100%, but the thing is we add the percutaneous approach when we fail to reach the lesion with the endobronchial navigation. Yeah.
Okay. And then another question was, when you do a biopsy, you always send it for frozen section. So you said that I don't have to wait. If you do one procedure, you go for frozen section on that specimen. Maybe another question then. Also, do you take more than one biopsy? I can imagine if you do a frozen section, you don't have enough for other analysis anymore.
Yeah, I usually we use to do cytology analysis. We don't have on site, but the pathologic lab is just 2 minutes from the hour. If you plan to do an ablation, you need to know if this is a lung cancer. Of course, you have to wait for the final diagnostic. You don't need it at this moment, depending on the quality of the sample. Sometimes I took more than 3-4 samples using the needle aspiration. If we are able to reach the lesion with forceps, I took always 2, 3, 4 samples. And if the quality of those samples are okay, I don't send to frozen section or to on-site cytology. But I think depending on your plan during the surgery, you can do needle aspiration or biopsies and go ahead. Don't wait to the final diagnostic if you are sure that you are in the lesion, because you can check with the CT scan.
Okay. You said you do ablations in patients who are not a good candidate for SBRT. Can you comment on that? When do you prefer ablation? When SBRT?
Oh yeah, we are conducting now a study, just analyzing the effect of the ablation using electromagnetic pulse electric field. This is kind of electroporation. This is a really nice and interesting working, but is research. Is not yet in clinical practice. Of course, patient with previous radiotherapy with relapse of the disease close to the treated area with radiotherapy, I think there are good candidates for ablation compared. The other thing is, in favor of the ablation is you can do ablation and it's fail. You can do then radiotherapy. It is complicated to do if you do first SBRT, but I think we don't have yet enough evidence to support this approach.
Okay. And then maybe last question to come back on that training. So you really are in favor of having all thoracic surgery trainees having a good training in bronchoscopy and interventional bronchoscopy for the future.
Absolutely. This is, we learn from our colleagues from cardiac, and I think we cannot lose our field. We are prepared for that, and we are in the beginning. The majority of the thoracic surgeons, we are well trained in using advanced bronchoscopy, and we need to use this. We are more familiar to use intraoperative approaches. We are more familiar deciding. Sometimes we decide this is not for surgery. This is the best option for this case is not surgery, is SBRT. But we are able also in some time to say probably this is a good candidate for ablation, and we can do it. We can be part, not just other specialists. The owner of the bronchoscopy is not the pulmonologist. It's, the bronchoscopy is just a tool. It's not like a horses, like a needle holder. Is the owner. We are all owner of this technology.
I could not more agree with you. Okay, thank you very much. It's almost 7:00. For me, today was a great ESTS webinar again with more than 100 live attendees, many interactions. On behalf of the ESTS Learning Affairs Committee, I would like to thank you, Professor Jiménez, for this excellent webinar and the fantastic illustrations. I would also like to thank the leadership of the ESTS and especially Hassan Batirel and Nuria Nuvoa for the opportunity to be e-learning coordinator for the last 4 years and moderator of 32 educational webinars. I would also like to thank my colleagues of the Learning Affairs Committee for their support and you, the loyal ESTS webinar audience, for your interest, interaction, and enthusiasm. Next year, webinars will be organized by my successor, Clemens Eigner from Essen, and we hope to see you all next month during the live ESTS conference in Den Haag. Thank you again, and see you next month.
Thank you.